Afternoon, folks. Hope everybody is doing okay wherever you happen to be. This is going to be the first in my series of lectures for anatomy on the urinary system. If you are in my anatomy class, you should go on the Blackboard site and get the handout that I've created for this class, sort of a summary of the notes that will give you some important terminology so that you know how to spell things as we are going along. Now, the last few systems, we've been talking a lot about the movement of blood through the body. We've been talking a lot about the delivery of oxygen, the delivery of nutrients, all the ways in which these things pass through our circulatory systems. Now, one of the things that I've consistently been saying throughout this conversation, but we haven't really paid a lot of attention to yet, is the fact that blood is not only a system for delivering materials that cells need, it is also a system for carrying away the waste products that they produce. Virtually every metabolic process produces some kind of chemical wastes. Collectively speaking, we refer to those waste products as metabolites. M-E-T-A-B-O-L-I-T-E-S. Metabolites. So metabolites is a collective term for any of the various chemical waste products that are a byproduct of your body's chemistry. Now, there are several different ways of getting rid of these products, and all of these methods are called excretion. E-X-C-R-E-T-I-O-N. And there are a couple of different excretory mechanisms in our bodies. Our skin actually serves as an excretory organ. A small amount of metabolites, like excess ions and urea, pass out in your sweat. Your lungs have an obvious excretory function. They're releasing carbon dioxide as a metabolite. Your intestines, of course, have an obvious excretory function as well, getting rid of non-digested material from your food. But there are a whole lot of chemical wastes that are not easily removed from the body in this way. And therefore, we have an entire bodily system dedicated to taking care of that. And that would be our urinary system. U-R-I-N-A-R-Y, the urinary system. The urinary system is primarily our body's purification system. It's tasked with removing toxic waste from the blood, but also at the same time with conserving useful materials. It's good to point out that the urinary system, contrary to its name, is not just about making urine. The urinary system is in many ways your body's primary chemical regulator, and it's responsible for keeping the levels of crucial metabolites from rising too high and of critical nutrients from falling too low. Broadly speaking, urinary system has several different functions. First and foremost, excretion. The urinary system filters your blood, removes metabolic wastes, removes toxic molecules, removes excess ions, and where needed, excess water. All those things are then filtered out and used to produce urine, which is then eliminated from the body. But there are several other functions we're going to do along the way here. A second important function of the urinary system is going to be blood volume and pressure regulation. Now, you think about blood pressure, and naturally you think about the heart, and clearly the heart has a role in this, which we've already discussed. But the kidneys also control our body's overall fluid levels. Excess fluid can be shunted out of the body in the form of urine. So by regulating fluid levels, the kidneys have a very important effect on blood pressure. Think back to our lessons on blood pressure a while back, and you might remember that one of the factors in blood pressure is blood volume. And because the kidneys are controlling fluid volume in the body, they have a dramatically important effect on blood pressure as well. Thirdly, kidneys are engaged in the regulation of solute concentrations. There are a number of crucial solutes that your body requires, and they need to be present at crucial levels. You need to have a certain amount of sodium, a certain amount of chlorine, a certain amount of calcium and potassium and phosphates and other molecules, and you need these in certain concentrations per unit of fluid or per unit of tissue in order for your body's chemistry to work properly. The kidneys play a vital role in regulating those concentrations, either shunting out excess nutrients into the urine to keep them rising dangerously high, or helping to retain them in the body and making sure they don't get passed out in urine whenever the levels of those materials fall too low. It should come as no surprise here to hear that another function of the urinary system is going to be pH regulation. If we're talking about regulating all these various ions and particles in your blood, well, regulating the pH of your bloodstream seems like an obvious thing that we're going to be doing along the way. We're going to be helping to control pH balance by means of controlling what is or is not in the blood. Some less obvious functions of the urinary system. Urinary system plays an important role in the regulation of hemopoiesis. If you don't remember that term, Hemopoiesis. Hemopoiesis, which you might recall is the formation of blood. Now, the kidneys themselves are not a hemopoietic organ. They do not make red blood cells, but they do secrete a hormone called erythropoietin. 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 And erythropoietin, as you can probably guess from the name, is a regulator in the production of erythrocytes, or red blood cells. So, although the kidneys are not themselves making red blood cells, they are playing a vital role in how the body makes them. And finally, another less obvious function of the kidneys, vitamin D synthesis. The kidneys help to make a certain amount of the vitamin D in your body. You're aware, of course, that your skin is a primary organ for vitamin D synthesis, but the kidneys do some as well. So, a lot of different things going on here. Urinary system is quite chemically busy. So, what all is included? Urinary system has a couple of different structures. Let's kind of lay out our pathway up front here. We have the kidneys. You have paired kidneys, left and right. Your kidneys, of course, are carrying out the function of filtering the blood and producing urine. The urine that is channeled away from the kidneys then passes through two tubes called the ureters. Ureters, ureters. The ureters connect the kidneys to the urinary bladder. Now, we've got the urinary bladder. Don't misspell this. It's Bladder, not TT. The urinary bladder is a muscular sac within the abdomen, which stores urine until such time as it is voided from the body. And then finally, urine is passed out of the body through a channel called the urethra. Urethra. The urethra is going to be the final exit point by which urine leaves the body. Collectively, that pathway from kidney to ureter to bladder to urethra could be called the urinary tract. All right, so what I want to do is kind of take a tour through the urinary tract. Let's see what is happening along the way. Let's see what all parts we are going to encounter. Now, the obvious component of the urinary system that gets the most of our attention would be the paired organs called the kidneys, Kidney. The kidneys are roughly bean-shaped organs, kind of the same shape as a lima bean. Your kidneys are roughly the same size as your fists. They are located retroperitoneally. If an organ is retroperitoneal, retroperitoneal, if an organ is retroperitoneal, that means it is located outside of the peritoneum. It's not covered by the peritoneum, which you might remember is the membrane that covers most of your abdominal organs. Kidneys are behind the peritoneum, prefix retro means behind, tucked between the peritoneum and the posterior abdominal wall. They're located to either side of the vertebral column. Each kidney is surrounded by a thick layer of adipose tissue, a fatty layer, that helps to act as a shock absorber, protecting the kidney from outside forces. Immediately deep to that fatty layer, you're going to find that each kidney is surrounded by a connective tissue capsule called the renal capsule, R-E-N-A-L. Anytime you hear the word renal, that's something having to do with the kidneys. The renal capsule is made of a fibrous connective tissue, dense fibrous connective tissue specifically. You will find that superficial to that is a loose connective tissue called the renal fascia, Fascia. And the renal fascia serves to bind the kidney to the posterior abdominal wall. All of this, I should point out, is beneath the diaphragm. We're all within the abdominal cavity here, if I didn't say that before. Now, if you look at the medial surface of each kidney, the kidneys, like I said, they're bean-shaped organs. They're concave curves towards the outside. The inner curve of the little bean shape points medially towards the spinal column. In the center of each kidney, pointing medially, you will find a little opening called the hilus or hilum, H-I-L-U-S or H-I-L-U-M. Both of those terms are in use. That opening allows passage of the renal arteries, which supply blood to the kidneys, the renal veins, which carry blood away from them, as well as the ureter and several nerves. Now, cutting into the kidney itself, and if you might, I would recommend, it's not a bad idea to find the diagram in your textbook and take a look at this as you're going along so you can see what I'm talking about. But when you're looking at the kidney itself, it has two distinct layers. We have the superficial layer called the renal cortex, C-O-R-T-E-X, and we have the deep layer, the renal medulla, M-E-D-U-L-L-A. You might recall that a cortex is an outer layer, a medulla is an inner layer, in almost any structure where you hear about those things. Now, the cortex, the outermost layer of the kidney, is going to feature pillars of tissue called the renal columns, C-O-L-U-M-N-S. The renal columns connect the renal cortex and the renal medulla. Tucked between those, you will find the renal pyramids, P-Y-R-A-M-I-D-S, renal pyramids. The renal pyramids are cone-shaped structures, the wide part of the cone facing outward, the narrow part of the cone pointing inward towards the renal medulla. Those renal pyramids are going to contain the functional filtration units of the kidneys. More about that in a few minutes. Each renal pyramid is going to be tipped with a renal papilla, P-A-P-I-L-L-A. If you pluralize it, papillae, it's A-E at the end. The renal papilla empties into a passageway called a minor calyx, C-A-L-Y-X. Kind of the minor calyces, plural, by the way, C-A-L-Y-C-E-S, calyces. The minor calyces are going to all funnel inward towards larger passageways called major calyces. Number varies from one person to another. Each of your kidneys contains between 8 and 20 minor calyces and 2 or 3 major calyces. These funnel-shaped chambers are going to collect urine produced by the filtration units within the renal pyramids themselves. So our pathway is going to be renal pyramid, out through the renal papilla, urine goes to the minor calyces, then is channeled to the major calyces. Major calyces are ultimately going to converge on a space called the renal pelvis, P-E-L-V-I-S. The renal pelvis is the large cavity inside the kidney. Space inside the kidney is sometimes known as the renal sinus, but the renal pelvis is that final collecting chamber for the urine. The renal pelvis is directly continuous with the ureter. So our pathway here goes renal pyramid to renal papilla, minor calyx, major calyx, renal pelvis, and then finally urine exiting the kidney via the ureter. All right, so far so good. And so in terms of our division of labor here, cortex features renal pyramids and part of the renal columns. Medulla features the renal columns and the renal sinus. Within the renal sinus, you will find minor calyces, major calyces, and ultimately the renal pelvis. So that's our basic map. And we're going to get into some more details about other things as we go along, but that's your overall gross kidney anatomy. You dissect a kidney, cut it open. There's a video of this up on Blackboard. Then you can see everything that's going on internally. Now, I kind of glossed over a really important part, that most of the actual action of the kidneys, the actual chemical behavior they are engaged in, is going to be happening in the renal cortex within the pyramids. Specifically, you're going to find that each renal pyramid contains functional units called nephrons. 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 You might have heard the term nephrology. Nephrology is the branch of medicine or science dedicated to the study of kidney function. Now, the nephrons are going to be the functional units which produce your urine. Now, each nephron has a few parts. It consists of a renal corpuscle, C-O-R-P-U-S-C-L-E. It features a proximal convoluted tubule, C-O-N-V-O-L-U-T-E-D, and tubule, T-U-B-U-L-E. So there's a proximal convoluted tubule. There is a distal convoluted tubule. There is a nephronic loop. The nephronic loop is very often called by the old eponymous name, the loop of Henle. If you write it that way, you capitalize Henle. It is capital H-E-N-L-E. That's an older term. I prefer you use the term nephronic loop, but you'll hear a lot of nephrologists and textbooks call it the loop of Henle, so you better know what that term means. And then, oh, okay, that's pretty much it. Yeah, sorry, I got lost in my thinking here. So we have renal corpuscle, proximal convoluted tubule, loop of Henle joins it to the distal convoluted tubule. Those are the parts of our nephron. Each of them has its own roles to play in the process of filtering our blood to form urine. So let's begin at the beginning of the process. Let's begin with the renal corpuscle. The renal corpuscle itself has two distinct parts. It has the glomerular capsule, G-L-O-M-U. Wait, no, sorry. Got lost in my own spelling. Scratch that. G-L-O-M-E-R-U-L-A-R. Glomerular. Wait, did I even... I'm sorry, guys. I'm spelling a long word. It's early in the day, and I'm not thinking clearly. Okay, let's go try that again. G-L-O-M-E-R-U-L-A-R. There we go. Glomerular. Okay, so we've got the glomerular capsule, which is sometimes called by the eponymous name Bowman's capsule, capital B-O-W-M-A-N. I prefer to use glomerular capsule. The glomerular capsule is the enlarged end of the nephron. Glomerular capsule surrounds a capillary network called the glomerulus, G-L-O-M-E-R-U-L-U-S. Through the renal corpuscle, fluid will leave the blood and enter the glomerulus. From the glomerulus, fluid that is filtered out of the blood will pass into the proximal convoluted tubule, where it will pass through a filtration membrane along the way. By the way, a term I'm going to use a lot throughout this discussion, the fluid that we are moving along here, once it leaves the bloodstream, that fluid is referred to as the filtrate, F-I-L-T-R-A-T-E, the filtrate. So that's the fluid that has been filtered out of the blood. The filtrate will pass through the proximal convoluted tubule, which is going to begin the process of filtering the blood, retaining what needs to be retained by the body and passing on things that need to be passed out as waste. It will then pass from the proximal convoluted tubule to the loop of Henle, or nephronic loop. There we are going to continue this process of allowing things to diffuse in and out, water and solutes. From there, the fluid passes through the distal convoluted tubule. That is where it's going to complete the process of forming urine. It's going to empty from there into collecting ducts. Collecting ducts are little tubes that are going to connect the nephron from there to the papillary ducts that I mentioned before, the renal papillae, and from there into minor calyces. So that's the connection point here. You're going to have a bunch of nephrons in any given renal pyramid feeding into each papillary duct or renal papilla to empty the urine that's been produced into a minor calyx. So our pathway here is renal corpuscle, proximal convoluted tubule, nephronic loop, distal convoluted tubule, collecting ducts, papillary ducts, renal papilla, and then minor calyx, and follow the pathway from there. Now that was basically laying out the anatomy. We clearly didn't talk about the process here. Let's talk about what actually happens in the nephron. How do we go about making urine? So, process of urine formation has 3 basic steps: filtration, tubular reabsorption, and tubular secretion. I want you to keep in mind that tubular secretion and tubular reabsorption are kind of happening simultaneously in most parts of the nephron. So I list them as a progression there, but a little bit of both going on at the same time. So start with filtration. Filtration is the movement of water and small solutes across a filtration membrane. Let me give you some numbers here. In any given minute, you're sitting in your chair, body's just doing its normal thing. Every minute, approximately 21% of your blood passes through your kidneys. Remember that the average person has about 5 to 5.5 liters of blood in their body. Therefore, you're getting approximately a liter of blood per minute. A little bit more than a liter of blood per minute flows through your kidneys. Now that volume of blood contains, plasma as well as formed elements. The formed elements, assuming everything is going well, do not end up in the kidneys. They stay in the bloodstream. They are not filtered out. The waste products, the metabolites that we want to filter out, are going to be in the plasma part of the blood. If there's blood present in your urine, that's not a good thing. We'll talk about what that means in a little while. So the part that is filtering out is the plasma. We're not filtering all the plasma at once. On average, about 19% of the plasma that flows into the kidneys becomes filtrate. So we got about 20% of your blood going into the kidneys every minute. About another 20% passing through the glomerulus and becoming filtrates. So, on average, I'll spare you all some math here. That gives us a glomerular filtration rates, or GFR, of approximately 125 milliliters per minute. In other words, you've got about, an eighth of a liter of plasma entering your kidneys every minute. Now you got 5.5 liters of blood in your body. Doesn't sound like much, right? But again, I'll spare you some math. If you extrapolate that number out, that means that the total amount of plasma the kidneys filter per day is approximately 180 liters a day. Pretty good, huh? 180 liters. If you've got about 5 liters of blood in your body, what this basically means, if you, again, think through the math here, is that every volume of blood plasma in your body gets filtered about 36 times a day. So we are going to be putting this through a continuous filtration process. That's necessary because, well, your cells are constantly producing metabolites. We can't ever stop. Now, of that volume of plasma that filtered out of the kidneys, we are going to, taken in about 125 milliliters per minute. No more than about 1 to 2% of that, like I said, less than 1% of that is going to become urine. 99% of that plasma that was filtered out of the kidneys is going to be returned to circulation. Only about 1%, or a little tiny bit more than 1%, is going to end up as urine. In other words, that 125 milliliters that filtered out, only 1 to 2 milliliters are going to stay behind. Not a lot. And again, I'll spare you all some math here. That works out to approximately 1 to 2 liters of urine produced by your body per day. Average healthy adult, assuming normal activity, normal metabolism, is making 1 to 2 liters of urine every day. All right? Gives us some numbers to work with. Just wanted to give you a sense of where we are at. Now, the things that are being filtered out here, what's leaving the bloodstream, is primarily going to be a few specific things. Water is going to leave. Small solutes are going to leave. Individual ions, things like sodium or potassium or urea, tiny little molecules. Larger things typically do not filter out of the plasma. What's larger? Blood cells, both red blood and white blood cells, typically do not get filtered out here. You typically should not be finding blood in your urine. Platelets typically do not filter out. Platelets are too large to pass through the filtration membrane. Again, platelets in the urine, not a good sign. Most proteins are too big to pass through the filtration membrane. Plasma proteins, like your globulins, are typically not going to end up in the urine. They're typically too big for that. Now, sometimes you will see some pathologies here. The condition of hematuria, 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 that is the presence of blood in the urine. That is the presence of platelets or blood cells in the urine. That is almost always indicative of trauma to the kidneys or the bladder. Whenever you see blood in the urine, that's almost always a sign of trauma having happened to some other part of the urinary tract. Can also be a result of nephritis, 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 neph for nephron or kidney, itis, inflammation. Nephritis is inflammation of the kidneys, typically as a result of infection. Sometimes blood in the urine can be indicative of tumors, and sometimes blood in the urine can be indicative of kidney stones. If you've got kidney stones rattling around in there, they can damage the inner lining of the kidneys and cause bleeding. So all these are possible sources of hematuria. Now you can also have proteinuria, 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 which, as you've probably guessed from the name, is the presence of proteins in the urine. Now, a little bit of transient proteinuria is not actually unusual. Once in a great while, a little bit of protein will end up in the urine. But if this is happening consistently, it's usually a sign of damage to the kidneys. Proteinuria is actually, in fact, one of our first indicators of kidney disease, when your kidneys are beginning to fail. And a lot of times in early stages of kidney failure, you won't even notice. And proteinuria is a clinical sign that can say, uh-oh, something is wrong that is not showing you symptoms yet. Most common causes of kidney disease resulting from proteinuria are high blood pressure and diabetes, both of which can lead to kidney damage, which can result in proteins ending up in the urine. A couple of medications can result in proteinuria as a side effect. Kidney trauma, just like with blood in the urine, proteins can end up in the urine the same way. Certain toxins can cause damage to the kidneys that leads to protein getting into the urine. Once in a while, kidney infections can cause this. A lot of the same things that cause blood in the urine will let proteins into the urine as well by damaging the membranes that normally filter them. So that's a thing to keep in mind. There's more than one possible cause here. And also overproduction of proteins by the body. That can also lead to proteinuria. Multiple myeloma, which is a type of blood cancer. If you are pregnant and have preeclampsia, proteinuria is a common symptom as well. So a couple of different things can indicate for this. All right, now, anyhow, let's talk about the actual filtration process. The filtration between the bloodstream and the kidneys is driven by a pressure gradient. Now, you all know some things about pressure gradients from our discussion of circulation. You all know that whenever you've got higher pressure things are going to tend to flow towards the area of low pressure. To give you some perspective on this, blood is coming in to the nephron, and it comes into the glomerular capsule first. Now, you've got capillaries surrounding that glomerular capsule. You've got blood flow that has to come in, right? So you're going to have glomerular capillaries that are going to bring blood to the nephron, and they surround the glomerular capsule. Glomerular capillary pressure, GCP, is the common clinical abbreviation for that, in a normal healthy human is about 50 millimeters of mercury. So that's the normal pressure in the capillaries outside of the glomerulus. I'm sorry, outside of the glomerular capsule. Capsular pressure, the pressure inside the glomerular capsule. CP is how we abbreviate that, capsular pressure, CAPSULAR. Capsular pressure is normally only about 10 millimeters of mercury. So that means that under normal circumstances, there's about a 40 millimeter of mercury pressure gradient between the bloodstream outside the glomerular capsule and the pressure within it. And as a result, there is going to be a net movement of fluid from the glomerular capillaries into the glomerular capsule. And that's what's going to drive that. As that pressure gradient increases or decreases, that's going to affect the rate of filtration. So our filtration pressure, as we call it, is going to go up or down depending on a lot of factors, mostly involving the blood flow to the kidneys. If you have vasoconstriction, that is, if there's limited blood coming into the kidneys, then external glomerular capillary pressure will drop and the rate of filtration will go down. By contrast, if you have vasodilation and more blood flow is coming into the kidneys, glomerular capillary pressure is going to go up. And as a result, your rate of filtration will increase. This is one of the reasons, by the way, that high blood pressure can be damaging to the kidneys because you're forcing more fluid into them more rapidly. For the most part, this is auto-regulated. The auto-regulation of filtration is normally a thing that your body does pretty well on its own. The kidneys do not need to receive outside stimulus to do this. They receive sympathetic stimulation from renal blood vessels. You're going to find that your brain doesn't have to step in and say, oh, increase or decrease filtration. It's largely managed by vasoconstriction and vasodilation. I should point out also that severe stress or sudden circulatory shock significantly reduce renal blood flow and urine production. So that's another danger of circulatory shock, that when you're in circulatory shock, metabolites are not being filtered out properly. So that's the filtration step. We've got blood coming in to the kidneys. Renal arteries bring it in. It's distributed to the various glomerular capillary beds surrounding the glomerular capsules, and a pressure gradient between the glomerular capillaries and the pressure within the pressure within the capsule itself forces fluid out of the blood into the glomeruli. All right? So far, so good? Okay, so that's our filtration step. Now, once we have got the fluid in, it enters the glomeruli through the glomerular capsule, and now it can move into the proximal convoluted tubule. Now, this fluid that went out was in bulk. It was just carrying whatever happened to be dissolved or suspended within the fluid. Well, some of that is stuff we want to keep. I mean, there's no discrimination over what filters out at the capsular end. You know, anything that's in the plasma at the time is going to go out. So we need to concern ourselves here with tubular reabsorption, recapturing things that the body does not want to pass out in the urine. You will find that our nephron is surrounded by a lot of peritubular capillaries, Peritubular, peritubular capillaries. Prefix peri means around or in the vicinity of. Peritubular capillaries will reabsorb materials that the body wants to keep from the nephron. They will pass those materials to a blood vessel, special vessel called the vasa recta, V-A-S-A, recta, R-E-C-T-A. And from there, they will re-enter circulation via the renal vein. What's left behind after reabsorption will be the waste products that the body wants to get rid of, excess solutes, and a small amount of water. Now, after we enter through the glomerular capsule, filtrate passes into the proximal convoluted tubule. Proximal convoluted tubule is the primary site of reabsorption. A lot of solutes are reabsorbed here, things like sodium and potassium. Sodium and potassium pump is vitally important to this process. It drives the movement of a lot of solutes back out of the nephron. Water is reabsorbed here as well. Some substances are going to come in through the peritubular capillaries. Some materials are going to diffuse directly across the membrane of the nephron and into the interstitial fluid. Some materials that do this are going to be potassium, magnesium, calcium, chlorine, and of course, urea. And yeah, I just said that we reabsorb a certain amount of urea at this point. Some of it passes out through the membrane. It doesn't all go out immediately. All in all, when you're done getting through the proximal convoluted tubule, about 65% of the water and the solutes that the body wants to keep have been reabsorbed. That's about the amount that we're going to soak up. About 2/3 of the retention the body is going to engage in is going to be reabsorbed across the walls of that tubule. Now, from the proximal convoluted tubule, we're going to pass the filtrates into the loop of Henle, or the nephronic loop. The loop of Henle is going to have two parts, a descending loop of Henle that goes down and an ascending loop that goes back up. In the descending nephronic loop, we are going to actually increase the concentration of solutes in the filtrates, largely by removing water. We're going to soak up some more water here, and partly by actually adding some solutes. Some solutes are going to enter the filtrate through interstitial fluid and peritubular capillaries in the descending loop of Henle, adding some things that weren't captured in the first place. All in all, about 15% of the fluid volume of the filtrates is reabsorbed in the descending loop of Henle. Now we're going to go back up the ascending loop of Henle. In the ascending loop of Henle, we are going to remove 80% of, sorry, not 80%, I was one step ahead of myself. In the ascending loop of Henle, we are going to remove more solutes. This is going to be the last place that we significantly recapture a lot of the solutes that need to be taken up by the body. By the time we get out of the nephronic loop, fully 80% of the water that filtered out in the first place and 90% of the solutes that filtered out in the first place have been removed. What's left is about 9 to 10% of the original volume of fluid that went out. I'm one step ahead of myself here, folks. A lot of numbers to keep track of. So let's back up. Okay, so we get out of the nephronic loop. 80% of the water that originally filtered out has been recaptured by this point. About 90% of the solids have. Now we move into the descending loop of Henle. The descending loop. I'm so sorry, folks. I don't know why I keep getting lost here. The distal convoluted tubule is the last step. So we did proximal convoluted tubule, went through the nephronic loop. Now we are in the distal convoluted tubule. In the distal convoluted tubule, we are going to reabsorb about 9 to 10% of the sodium and the chlorine present in the filtrates, taking that back into the body. But we are also going to reabsorb about 19% of the water. Now remember, we only had 20% of the original water left, which means that by the time you get out of the distal convoluted tubule, you're leaving behind approximately 1% or less of the original filtrate. You have taken back about 99% of the original fluid volume and the solids. Just follow the bouncing ball with the math here. 65% reabsorbed in the proximal convoluted tubule, about 15% in the nephronic loop, and 19% in the distal convoluted tubule, leaving behind 1% of our original fluid volume that passed out. We now have a highly concentrated fluid, a little bit of water, with mostly wastes that we want to remove, which we collectively refer to as urine. That is the urine that is finally exiting the distal convoluted tubule. All right, sound good? All right, one last thing. I didn't talk as much here. I mentioned it in passing as we went along the way. That whole thing I've been discussing is tubular reabsorption, the recapturing of stuff that passed out with the filtrate that the body wants to hold on to. How about tubular secretion? Tubular secretion is the addition of materials to the filtrates after the initial filtration through the glomerular capsule. You will find that some materials, instead of filtering out at the glomerular capsule, will actually enter the filtrate through the peritubular capillaries. Examples of things that get into the nephron this way include hydrogen ions, potassium ions, histamines, excess histamines filter out in this way. The metabolic waste product creatinine, C-R-E-A-T-I-N-I-N-E, and ammonia. All of these things are going to enter the peritubular capillaries through, are going to enter the nephron through the peritubular capillaries and be added to the filtrate after it passes through the glomerular capsule. If you care, hydrogen, potassium, creatinine, and histamines are all going to be added to the nephron via active transport mechanisms. Ammonia is going to be added via passive transport mechanisms. This is not an all-encompassing list, folks. I'm not listing every single chemical that is going to be added to the filtrate in this way. There are a lot of tiny little quantities of things like formaldehyde. Your body makes a tiny amount of formaldehyde, which is added to the filtrate here, for example. A lot of drug products are also going to enter urine through the peritubular capillaries. Whenever anybody is taking drugs of any kind, we can usually determine what drugs they are taking from a urine test, because you'll find either a certain quantity of that drug or some of its byproducts from when it breaks down in your system present in the urine. So penicillin, for example, something that we can readily detect from the urine. THC byproducts can be found in the urine. That's why we do urine drug tests, right? Because that way we can find out what drugs people have been on. Now, a lot of this tubular secretion is going to happen in the nephronic loop. That's the primary site where we're going to be adding things to the filtrates. All right. Now, I mentioned one other thing along the way here, the vasa recta. The vasa recta is a quite important vessel that is part of all of this. The vasa recta has two jobs, actually. The vasa recta both provides oxygen and nutrients to the nephron. It brings in things that the nephron itself requires for its function. And two, it removes wastes from the nephron. The nephron itself, despite being a filtration mechanism, is going to be producing its own metabolic wastes. And the metabolic wastes produced by the nephron are not automatically just dumped straight into the filtrates. They have to be collected through the bloodstream like everything else. And the vasa recta is going to be doing that. It's going to be bringing in fuel and oxygen for the nephrons. It's going to be taking away the nephron's own metabolic waste products. In addition, the vasa recta, as I indicated, is going to collect solutes and water that are reabsorbed by the nephrons. Those things are going to pass into the vasa recta and then be returned to circulation. So the vasa recta is a really important vessel. It's got a few different jobs in the course of our process of kidney filtration. All right, sounding good? Okay, how do we regulate all this? We have to control what is going in and what is out, right? Now, let's think about a few things for a moment. Let's think about water. You take in more water. We have to deal with the fact that everything else is more dilute. If you have a large volume of excess water in the body, high water consumption is going to mean that you need to eliminate a large volume of excess fluid, but not simultaneously eliminate too many electrolytes. We have the risk that if we're eliminating lots of water, that we're going to eliminate electrolytes along with it. In other words, we have to have a way of producing a large volume of dilute urine with less solutes in it whenever you have a lot of water to get rid of. Conversely, let's suppose that you have less water. Let's suppose your body has less free water available. Either you're not consuming as much, you're using a lot up via sweating, whatever. If that's the case, we need to have a mechanism of retaining more water. We have to make sure the kidneys are not shedding water that the body requires. Therefore, we need a regulatory mechanism to produce a smaller volume of more concentrated urine. The concentration of urine is quite important. If you pass too much fluid without lowering the concentration of the solutes in it, you're going to lose crucial electrolytes. Conversely, if you pass too little fluid without increasing the concentration, you're not going to be adequately filtering out metabolites. So there's a seesaw relationship here that has to be maintained between the volume of urine and the concentration of solutes within it. We have a couple of different hormonal mechanisms for helping to control this. Hormones are vital to this process. There are several different hormones that are going to be involved. Now, you already have heard of a few of these. Think back to our endocrine system. Some of these names are going to sound familiar to you. First off, let's talk about antidiuretic hormone, or ADH for short. It's ANTIDIURETIC. Now, a diuretic, you probably know that term medically speaking. A diuretic is something that makes you urinate. Antidiuretic hormone is therefore a thing that's helping your body to retain fluid volume. Now, reminder, ADH is secreted by the posterior portion of your pituitary gland, the hypophysis, you might recall. Now, in the hypothalamus of the brain, let's go back to our brain. The hypothalamus, you might recall one of its many functions is regulating thirst. And here's why. Because the hypothalamus of our brain contains specialized cells called osmoreceptor cells. OSMORECEPTOR. Osmoreceptor cells. The osmoreceptor cells in the hypothalamus monitor the osmolarity of your body's interstitial fluids. And if you don't remember that term from way back in Bio 1, osmolarity, to simplify the chemistry here, is the overall concentration of stuff in a fluid. It's not the concentration of any one specific solute, it's the overall concentration of solutes relative to the volume of water. So our hypothalamus is monitoring the osmolarity and seeing when it goes up and down. Now, if the osmolarity of our body fluids begins to fall, in other words, if the overall concentration of solutes becomes lower relative to the volume of fluid, then what's going to happen is our brains are going to inhibit ADH. They're going to make less ADH. Why is that? ADH is antidiuretic hormone. If you have a high fluid volume relative to solutes, you want to concentrate your bodily fluids more so that important nutrients don't become dilute. That means we want to pass a larger volume of fluid in the urine. So suppressing ADH, which is antidiuretic, will therefore have a diuretic effect. So anytime that osmolarity in your body fluids falls, ADH is suppressed. So ADH, sorry, hold on a second, guys. I'm really sleepy. I'm going to take a minute. I'll be right back. Sorry, folks. So got a little bit flustered there for a second. Bad insomnia last night. Carrying on. So I think the best way to explain ADH is to talk about what it actually is doing here. That when ADH levels rise, that is going to increase the permeability of the distal convoluted tubule to water. You might recall the distal convoluted tubule is soaking up water. It's reabsorbing water. So as ADH levels rise, the distal convoluted tubule resorbs more water. As a consequence, you're going to reduce the volume of urine. So higher ADH levels, more water reabsorption, more tubular reabsorption, and therefore lower urine volume. Conversely, go the other way. If ADH levels are low, that's going to reduce the permeability of that tubule to water, which means less water will be reabsorbed, and therefore you will pass a larger volume of more dilute urine. So higher ADH, your body retains more water. Lower ADH, you pass more urine, and more dilute urine, I should say. I should also point out that your ADH levels are responsive to changes in blood pressure. I had mentioned before how the kidneys have a vital role in the regulation of blood pressure. If your ADH levels, if your blood pressure rises or falls by even 5 to 10%, that will cause changes in your levels of ADH. A decrease in blood pressure will cause your levels of ADH to go up. Lowered blood pressure stimulates increased secretion of ADH. That has the effect of causing your body to retain more fluid and therefore raise the fluid volume of your blood and raise your pressure. Conversely, if blood pressure rises, as a way of counteracting that, our bodies secrete less ADH. That means that more fluid is shunted into the kidneys and released in urine, reducing blood volume and, by extension, reducing blood pressure. So that's what ADH is all about. More ADH, your body retains more water, blood pressure rises, urine volume falls. Less ADH, your body releases more water via the kidneys, urine volume increases, blood pressure falls. All right, sound good? Okay, how about another one? Let's talk about aldosterone. Aldosterone is a hormone secreted by the adrenal glands. You might remember that from your section on the endocrine system. There's actually a rather complicated cycle of making aldosterone where it begins with an enzyme called renin, which acts on a precursor called angiotensinogen, which forms angiotensin 1, which is converted to angiotensin 2 by angiotensin converting enzyme, or ACE, which in then turn stimulates the adrenal glands to release aldosterone. I'm not going to ask you to know about that whole cycle, folks. Suffice to say, aldosterone is secreted by the adrenal glands in response to signals from a chain of other hormones. Now, once aldosterone is secreted, it travels to the distal convoluted tubules and it binds to intracellular receptors there. The effect of aldosterone is that it stimulates the uptake of sodium and of chlorine from the filtrate, the reabsorption of sodium and chlorine. Now, if you know your blood chemistry or you know your general chemistry, the rule with osmosis is that water follows solutes. Wherever the solutes go, water is going to drag along after them. Solvent drag, we call it. So, whenever salts are reabsorbed, whenever sodium and chlorine are reabsorbed by the distal convoluted tubule, water will be reabsorbed along with them, and water will also filter back into circulation. Thus, what aldosterone has the effect of doing is that it regulates blood volume by controlling the sodium content of your blood. By increasing sodium levels, our bodies compensate by storing more water to balance out the osmolarity. As a result, by increasing sodium retention, we can increase blood pressure and blood volume without changing the osmolarity of blood. And that's what aldosterone is really doing, that it's causing us to reabsorb sodium and along with it water, and therefore raise blood pressure without significantly changing osmolarity. Now, by contrast, if your aldosterone levels drop, your body is going to secrete more sodium. You're going to release more sodium in the urine, and by extension, water follows solutes. More water is released in the urine as well. So the effect of lower aldosterone levels is that you release more salts and you have larger fluid volume in the urine, and effectively reduces blood pressure as well. I should point out a fun little fact here, that renin, the initial enzyme that stimulates the chain of events that make aldosterone, renin secretion is affected by changes in blood pressure. If blood pressure drops, which often means lower sodium levels, then that means that renin will be stimulated so that you retain more sodium, and by extension, your blood pressure goes up. By contrast, if your blood pressure rises, you're going to find that aldosterone levels are reduced, and thereby you excrete more sodium and blood pressure falls. Now, this hormonal mechanism has just illustrated a really important point that many of you know from medicine, but now you know why. Namely, that there's a strong relationship between high sodium and high blood pressure. The more sodium your body retains, the more fluid volume it retains, and as a consequence, your blood pressure rises. So this is why whenever you have high blood pressure, they tell you reduce sodium levels in your diet. All right, sounds good? All right, last but not least, in terms of our hormone control mechanisms for regulating the action of the kidneys, let's talk about atrial natriuretic hormone, or ANH for short, sometimes called atrial natriuretic peptide, ANP. Either of those is acceptable. I realized I did not necessarily spell things here. I should be spelling things for you all. Aldosterone is ALDOSTERONE. Renin, the precursor for it, is RENIN. And atrial natriuretic hormone, I think you know atrial by now. Natriuretic is NATRIURETIC. Now, atrial natriuretic hormone gets its name because it's secreted by cardiac muscle cells, specifically from the wall of the right atrium. It's an endocrine function carried out by the heart itself. Now, ANH is released in response to rising sodium levels. Whenever blood volume increases, what's going to happen here is that ANH inhibits sodium reabsorption. It lowers the rate at which the kidneys reabsorb sodium. It also inhibits ADH, inhibits the secretion of antidiuretic hormone. So they're antagonists to each other. ANH antagonizes ADH. The consequence of both reducing sodium levels in the blood and reducing levels of ADH is that urine volume will be increased and blood pressure will drop. We will find that ANH also has the effect of dilating arteries and veins. It stimulates vasodilation, and that has a further effect of lowering your blood pressure. So ANH is a very significant factor in how we keep blood pressure down. Now, you may have noticed that these three hormones are sometimes working against each other. You've got ADH trying to retain fluids. You've got aldosterone retaining both salts and fluids. You have ANH coming in and saying, no, let's dump all those things. All these hormones are going to be active in your body and at the same time to varying extents. The levels of them will go up and down relative to each other, depending on how much water and how much sodium your bloodstream needs to maintain homeostasis. So don't think of this as like, oh, okay, we're done with ADH for now. Let's turn it off and start making ANH. No, it doesn't work that way. They're both present in some concentration at the same time. And the levels of them increasing or decreasing will affect the overall blood volume and sodium levels relative to each other. And along the way here, as you can see, regulating blood pressure. This is a very important part of how we control blood pressure overall and how your body responds to changes in blood pressure. All right, so we've now talked about how the kidneys do the thing they do. We've talked about how we make the urine. We've talked about hormonal regulation of this process. What happens next? So let's trace the movement of urine, because the kidneys are only the beginning of the urinary tract. Now, once urine is produced, we already know part of the pathway. It exits the nephron, goes into the collecting ducts. Collecting ducts channel it to papillary ducts and out via the renal papillae. From there, the urine is collected by minor calyces, which then empty into major calyces, and finally into the renal pelvis. Now, this is easy to do. It's driven by a pressure gradient. You might recall that the capsular pressure within Bowman's capsule is about 10 millimeters of mercury. On the other hand, the pressure in the renal pelvis is only slightly above zero. Very, very low pressure there. As a result, there will be a net flow of filtrate and eventually urine through the nephron and into the renal pelvis. Now, once urine has entered the renal pelvis, it will flow from there into the ureters. The ureters are small tubes which lead away from the renal pelvis and into the urinary bladder. Now, because the pelvis has such a low internal pressure, we got to find a way to move that fluid along. So the ureters are going to experience peristaltic contractions. Remember, peristalsis is a wave of contraction that passes along the length of a tube. It's like squeezing a toothpaste tube from the bottom. So the tube begins squeezing at the proximal end. That wave of contraction ripples its way down to the distal end, pushing the urine ahead of it. On average, the pressure in the ureters is higher than 50 millimeters of mercury. And as a result, there's going to be a net pressure moving forward into the urinary bladder. This occurs depending on how much fluid is available, anywhere from every few seconds to every 3 minutes. Now, when ureters arrive at the urinary bladder, they pass through its wall at an oblique angle. And what that means is that part of the wall of the bladder folds over the opening to the ureter. That's important because that compresses the ureter when nothing is flowing through, and therefore prevents the backflow of urine going back up into the ureter. Now, we've got the urinary bladder. Urinary bladder is a muscular hollow sac located in the pubic cavity. It is immediately superior to the pubic symphysis. That's bony point where the pelvic bones meet, just above the genitalia. In men, the urinary bladder is positioned just anterior to the rectum. In women, slightly different positioning. The urinary bladder is positioned just anterior to the vagina. And let's not confuse the words vagina and vulva here. We often misuse them in day-to-day life. That external structure, that's not the vagina, that's the vulva. The opening in the middle of it is the vaginal orifice, the muscular tube inside that leads to the rest of the female reproductive tract. That tube is the vagina. And the urinary bladder is located anterior to that in women. Now, the size of the urinary bladder is going to depend on the urine contents. Whenever there's no urine present, the internal pressure of the urinary bladder is like 0. But whenever there's 100 milliliters of urine present, its internal pressure will be about 10 millimeters of mercury. Nice day, folks. Allergies. All right. So, little by little, as you increase the urine volume of the bladder, the pressure within it rises. Slow increase, pardon me, up to about 300 milliliters of urine stored in the bladder. After that, the pressure begins to really spike. So not a lot at first, but from that point onward, it begins to get higher and higher and higher. Maximum capacity of an adult human bladder, average adult human bladder, is about 1,000 milliliters. In other words, about 1 liter is about the maximum you can hold in that bladder at once. You will almost never end up holding that much, for the simple reason that long before it gets that full, you're going to be experiencing significant stimulus to eliminate it. That's more the pressure in the bladder grows, the more you're going to feel an instinctive need to void the urine. Now, talk more about that reflex in a few moments. Let's now discuss the pathway out of here. Now, from the urinary bladder, urine is going to exit by way of a tube called the urethra. U-R-E-T-H-R-A. The urethra is the tube which carries urine out of the body. At its proximal end, it joins to the inferior end of the urinary bladder. It's oriented differently in men and women. In men, the urethra extends into the penis, and the external urethral orifice is the same opening used both to release urine and to release semen during sexual intercourse. As a result, the urethra in men is longer than the urethra in women. It has a longer area to pass through. On average, the male urethra has a length of approximately 20 centimeters. Now, the female urethra is passing a much shorter distance. It only travels to a small opening called the vestibule, V-E-S-T-I-B-U-L-E. The vestibule is located immediately anterior to the vaginal orifice in women and immediately inferior to the clitoris. Now, the female urethra is a lot shorter than the male urethra, only about 4 centimeters long on average. That's one big anatomical difference between the two. We'll get to another one momentarily. Now, the entire length of this tract, the ureters, the urinary bladder, the urethra, it is all lined with a mucous membrane. Specifically in the ureters and the urinary bladder, it's going to be largely a transitional epithelium. Think way back to Bio 1. When you're thinking about your epithelial tissues, transitional epithelium is the one that's 5 to 6 cell layers thick when it's relaxed, but it can stretch and the cells compress together, and it's only 2 to 3 layers thick whenever it's stretched. This is necessary to accommodate the stretch of the bladder as it expands and the flow of urine as the urethra expands when urine is pushed into it. Now, the urethra has a lining that is partly transitional epithelium along most of its length, but at the distal end, the urethra's lining is going to change. It's going to be a non-keratinized, stratified squamous epithelium. And the reason for that is because stratified squamous epithelium, you might recall, thickest epithelial tissue, that provides the best defense against pathogens that might enter the urethra. The external urethral orifice is one of a few openings out of the body. It is possible for bacteria to get in that way, and a non-keratinized stratified squamous epithelium is a really, really good place to deflect the penetration of further bacteria, in much the same way that the keratinized stratified squamous epithelium on the surface of your skin keeps bacteria away from deeper tissues. Now, if you look at the wall of the urinary bladder, you will find that it contains a layer of smooth muscle called the detrusor, D-E-T-R-U-S-O-R. The detrusor is the smooth muscle of the urinary bladder. It contracts to force urine into the urethra. Now, another anatomical difference between men and women. In men, there are actually 2 sphincters which control access to the urethra. There is a proximal, or the proximal end one, and a distal end one. The internal urethral sphincter, and sphincter, remember, is S-P-H-I-N-C-T-E-R, and a sphincter, remember, is a ring of muscle. So men have an internal urethral sphincter at the proximal end of the urethra. That is a smooth muscle sphincter. You have no conscious control over it at all. It's the junction of the bladder and the urethra. Women have a vestigial structure there that is not a functional sphincter. Women only have an external urethral sphincter that actually works. Both men and women have an external urethral sphincter located at the distal end of the urethra. That's the opening to the outside of the body. The external urethral sphincter is a skeletal muscle sphincter, meaning that we have conscious control over it. Now, you might ask yourself, why do men have 2 sphincters and women only have 1? Quite simply, because men have to use the penis for more than one thing. For women, the urethra has one function and one function only, that is to release urine. That's the only thing it does. For men, the urethra has to release both urine and semen. So the purpose of the internal urethral sphincter in men is to close off the bladder during ejaculation. It prevents men from releasing urine along with semen. So men need that in a way that women do not. Now, there's an important consequence for this, folks, and that consequence is that a combination of two factors here. One, women have a way shorter urethra than men, about 1/5 the length of the average male urethra. And two, women have one fewer sphincters than men. This means that in general, the female body is less protected from bacteria getting in via the urethra. There's one fewer sphincter to close them off, and there's a shorter passageway for them to move up. As a result, women are considerably more prone to urinary tract infections, or UTIs, than men are. The female urinary tract simply does not pose as many obstacles to bacteria getting in. Furthermore, you will find that as we get older, both men and women tend to experience problems with urinary incontinence as they age. The sphincters become less tight, they relax more easily. Women experience this to a much greater extent than men, partly because they have less of a tube for the urine to travel down for it to make its way out. They also have one fewer sphincter in the way. As a result, many more elderly women have incontinence problems than elderly men. Now, can't talk about UTIs without mentioning a very important piece of folk wisdom. If you ever had a UTI, I am sure somebody has told you, drink some cranberry juice. Why would this be? Okay, so the idea behind this is that cranberry juice is high in two compounds that might be helpful here. Fructose, the basic fruit sugar, and a substance called proanthocyanidin. Proanthocyanidin. That's PROANTHOCYANIDAN. Proanthocyanidin. It's a tannin. That is a defensive compound found in plants. Tannins are a big part of how plants protect themselves from both UV rays and pathogens. We have discovered that proanthocyanidin has antibacterial effects on the lining of the bladder. Fructose also has some mild antibacterial effects. Now, ideally, there should not be a lot of fructose present in your urine. Sugars in the urine, generally not a good thing. Generally, we see that as a sign of diabetes. But if you've got a kidney infection, inflammation and irritation of the kidneys, as you've already seen, can cause things to end up in the urine that otherwise would not be there. And therefore, it's more likely for sugars to enter the urine when you have a kidney infection. That has the beneficial effect of fructose from the cranberry juice helping to make the environment more hostile to bacteria. And proanthocyanidin can also get into the urine and therefore create a more hostile environment from bacteria. Now, clinical studies on how effective cranberry juice is have been limited and are of somewhat mixed results. But what most doctors will tell you who have looked at this is that if you want cranberry juice to have any efficacy, you want to make sure that you're drinking a juice that's at least 30% actual cranberry juice content. A lot of the quote-unquote cranberry juice cocktails you get on the grocery store shelves have a significant amount of apple juice mixed into them, much more apple than cranberry in a lot of cases, or other juices mixed in. Grape juice is not an uncommon one. You want at least 30% cranberry juice itself. You can get pure cranberry juice. That's the best bet. So it's one of those rare cases in which the folk wisdom actually has something going for it. There does seem to be some legitimacy to the idea that this will help reduce the incidence of urinary tract infections. Or at least not so much reduce the incidence of, it's not going to help you keep from getting them. What it will do is help you to get over them faster, help you to eliminate bacteria from the urinary tract more easily. Okay, so that's our basic map of the pathway of the urinary system, the flow of urine, the basic anatomical structures involved, how we produce urine to begin with. But we are not done with the urinary system yet. We have several other topics related to this to discuss. However, I think I've given you about a good length of time here. This is about a standard class period. So I think we will cut this one off. In our next lesson, we'll carry on to learn a bit more about kidney physiology. We'll learn a bit more about specific nutrients and how and why they are kept, and a little bit more about how the kidneys are related to phenomena like blood pressure regulation and some select kidney pathologies too. I'll see you all soon. Have a good day.